Statins are a class of medication designed to do one primary thing: lower LDL cholesterol, the kind commonly referred to as bad cholesterol, in the bloodstream. They do this by blocking an enzyme in the liver called HMG-CoA reductase, which is responsible for producing cholesterol. Less enzyme activity means less cholesterol produced, which means lower levels circulating in your blood and depositing along your artery walls. They're among the most prescribed medications in the world, and they've been studied more extensively than almost any drug in modern medicine. The evidence base behind them is substantial, but substantial evidence for a medication existing doesn't automatically mean that medication is right for every person who gets handed it. So why do doctors recommend them? Several reasons, and they're worth understanding clearly. The most straightforward is high LDL cholesterol, specifically levels elevated enough that lifestyle intervention alone is unlikely to bring them into a safe range within a clinically meaningful time frame. The second is existing cardiovascular disease. If you've already had a heart attack, already have coronary artery disease, or have already experienced a stroke or TIA, statins aren't just about prevention anymore. They're about reducing the very high risk of a second event. The third is a combination of risk factors that individually might be manageable, but together create a risk profile serious enough to warrant medication: diabetes, high blood pressure, smoking history, family history of early heart disease, and age, particularly for men over 45 and women over 55. When several of these stack together, the math shifts in favor of medication, regardless of whether cholesterol levels alone look dramatic. What statins actually do inside the body goes beyond simply lowering a number on a lab report. They reduce the buildup of plaque inside arterial walls, the fatty, inflammatory deposits that narrow arteries and make heart attacks and strokes possible. They also have anti-inflammatory effects on the arterial lining itself, which is part why their benefit extends beyond what cholesterol numbers alone would predict. For people with established heart disease or high cardiovascular risk, the long-term protection they offer is real and well-documented. Reductions in heart attack risk, reductions in stroke risk, and in high-risk populations, reductions in overall mortality. This is not pharmaceutical marketing. It's decades of clinical trial data across hundreds of thousands of patients. For the right person, statins are genuinely life-saving. But here's where the conversation gets more honest than it sometimes does in a 10-minute doctor's appointment. Not everyone prescribed statins is that person. If your cardiovascular risk is low, if your LDL is mildly elevated but your blood pressure is well controlled, you don't have diabetes, you've never had a cardiac event, you're not a smoker, and your family history is clean, the absolute benefit of statin therapy becomes much smaller. The relative risk reduction that sounds impressive in a headline translates to a much more modest real-world benefit when your baseline risk is already low. In these cases, lifestyle intervention is not a consolation prize or a delay tactic. It is a legitimate, evidence-supported first line of action that for many people produces sufficient results without introducing a daily medication and its associated considerations. Those considerations are worth naming directly because they're the source of a great deal of anxiety. Muscle pain, myalgia, is the most commonly reported side effect of statin use, affecting somewhere between 5 and 10% of people who take them, though the numbers vary depending on the study and the statin in question. For most people who experience it, it's mild and manageable. For a smaller number, it's significant enough to prompt a change in medication, a dose adjustment, or a switch to a different statin. Serious muscle damage, rhabdomyolysis, is rare but real and is something to be aware of rather than dismissed. Liver effects are frequently cited as concern, but clinically significant liver damage from statins is genuinely uncommon, and routine liver monitoring during statin therapy has largely been scaled back because the risk simply doesn't justify the testing burden for most patients. The fear of long-term medication use is real and understandable. Nobody wants to be on a daily pill indefinitely if they don't have to be. That's a legitimate concern worth raising with a doctor, not suppressing. The lifestyle alternative deserves genuine respect rather than the slightly dismissive treatment it sometimes gets in clinical settings. Diet, specifically reducing saturated fat, eliminating trans fats, increasing soluble fiber through oats, beans, and vegetables, and incorporating plant sterols, can lower LDL cholesterol meaningfully. Regular aerobic exercise raises HDL, the protective cholesterol, and contributes to overall cardiovascular health in ways that extend well beyond lipid panels. Weight management, particularly reducing visceral abdominal fat, improves insulin sensitivity and reduces several cardiovascular risk markers simultaneously. For people whose risk profile places them in a gray zone, elevated cholesterol without established disease or multiple compounding risk factors, a structured 3 to 6 month lifestyle intervention is a reasonable and evidence-backed approach before moving to medication. The key word is structured, genuinely committed dietary and exercise change, not a vague intention to eat better. But here's the warning that needs to be stated without softening. Do not stop taking statins because you read something alarming online, because a friend had a bad experience, or because you feel fine and can't imagine needing medication. Feeling fine is not a reliable indicator of cardiovascular risk. Plaque buildup in arteries produces no symptoms until it produces a heart attack. People who discontinue statins after a cardiac event significantly increase their risk of a second one. The decision to start, adjust, or stop statin therapy is a medical decision that belongs in a conversation with your doctor, one where your specific numbers, your specific risk factors, your specific medication history, and your specific health goals are all part of the equation. Personalized decisions produce better outcomes than generalized ones, in either direction. Some people should have that conversation leaning clearly toward yes. If you have established coronary artery disease, existing blockages, stents, bypass history, statins are part of standard care for good reason. If your LDL is severely elevated, particularly if familial hypercholesterolemia runs in your family, lifestyle alone is unlikely to move the needle sufficiently. If you've already had a heart attack or stroke, the evidence for secondary prevention with statins is among the strongest in all of cardiology. For these individuals, the question isn't really whether statins make sense. It's which one, at what dose, and how to manage it well over time. Statins aren't for everyone. That's true, and it's worth saying clearly in a medical landscape that sometimes defaults to prescribing them more broadly than the evidence strictly supports. But for some people, for the person with the blocked artery, the previous heart attack, the severely elevated cholesterol, the stacked risk factors, they are genuinely, measurably life-saving. The goal isn't to be on medication or to avoid medication. The goal is to make the right decision for your specific body, your specific risk, and your specific life. And that decision is made with real information, an honest conversation with a physician who knows your history, and the willingness to take your cardiovascular health seriously, whether that means a prescription or a committed change in how you eat and move. Your heart doesn't care whether protection comes from a pill or a lifestyle. It just needs a protection. Make sure it gets it. If this gave you clarity on a conversation you've been putting off, subscribe for more videos that break down health decisions for adults over 50 in plain, honest language. Share it with someone weighing this decision right now. And like the video if it helped. It tells us what's worth making more of